Tim is easily one of the industry's leading speakers on coding. You see his name all over conferences during the year. Very, very trusted source on coding issues. Great reputation at Episource, and I'm excited to have some coding focused conversations, because coding is such a big challenge right now. The nuances around coding, and they are nuances and constantly changing, huge changes between 9 and 10. So I'm excited to have a conference just focused, or a session just focused on this. Samantha, I'm just meeting for the first time, but I'm very familiar with Providence Health Plan, and I'm excited to have somebody on the plan side that is absolutely in the trenches day to day on this from a plan perspective. So I think we've got a great dual focus on this topic, and so I'm just going to turn it over to you, Tim. Thanks.
Thanks, Dave, and good morning, everyone. This is Nuances of Risk Adjustment Coding under ICD-10-CM. I am Tim Buxton, the Director of Coding Services at Episource, and Samantha is going to follow me here. She is at Providence Health Plan, as Dave mentioned. We wanted to talk about the nuances of dealing with risk adjustment under ICD-10. Now that ICD-10 is almost a year old, and what have we learned, what have we encountered trying to apply it specifically to the risk adjustment environment and to risk adjustment coding. So that's the idea behind sort of this presentation and this session today. ICD-10, as I mentioned, is almost a year old. For some risk adjustment purposes, some organizations, such as Medicare Advantage plans, are just really starting to utilize it, because now there is when they're really knee-deep in the 2015 dates of service, because, of course, the final submission deadline for those would be this January. So a lot of folks have just been dealing in ICD-9 still, if they're in risk adjustment, even though it's been almost a year since ICD-10 came out, because their reviews were focused on 2014 up until January of this year, and then now on 2015 dates of service. And if you sort of start at the beginning of the year, you're just now dealing with the latter part of that. So in some ways, there are some risk adjustment organizations just now having to take ICD-10 into account and figure out how to deal with it. And hopefully they haven't waited until this point to do that. When we think about plans on the health insurance exchanges, HIX is my little abbreviation for health insurance exchanges, or commercial risk adjusted plans, and anyone with a more prospective approach. So any place that you're dealing with something within a couple of months at least of the date of service, if not immediately at the time of service, those folks have been dealing with ICD-10 for a while now, because the deadlines and the review period is so much shorter. So the thought or the idea here is what has been ICD-10's effect on risk adjustment coding? How can HCC coding be performed successfully in this new environment with this new code set? So to that end, we want to talk a little bit about new aspects and features of ICD-10 that we need to be aware of as we do risk adjustment coding. ICD-10 areas of confusion and of concern. We'll want to look at AHA Coding Clinic, how it's been applied thus far to ICD-10 and some of the key elements there. 2017 ICD-10 updates. Of course, in just a couple of weeks now, the new year's worth of ICD-10 codes, the 2017 ICD-10 codes will come out. So last couple of months, ever since we got sort of a heads up on what would be included, there's been a lot of discussion. And we want to think about those updates, and specifically which of those updates apply to the risk adjustment environment and how those updates apply. And specific HCCs and diagnoses of interest. We'll go through a little bit on HCCs where the ICD-10 coding maybe is very different from the ICD-9 coding or is particularly challenging, and take a look at that and how it applies here. So ICD-10's new tricks. Obviously we know ICD-10 offers much greater specificity in a number of areas. in some cases, certain details will determine whether a code is risk adjusting or not. And it seems like in ICD-9, when we talk about risk adjustment, an HCC encompasses a relatively broad category of conditions, and there's a large, everything in that category, so to speak, applies to the HCC. So, chronic kidney disease, well, that's a bad one with stages, but everything applies to that HCC, everything that's pretty much relevant. When we get to ICD-10 and we start being more specific about diagnoses and about conditions, suddenly the HCC is also more specific. And if we look at the mapping to ICD-9 versus the mapping to ICD-10, there's now this situation where the big one is going to be injuries, right? Only the initial care for a fracture is going to count here. So we have to make sure the ICD-10 code has the A as the 7th extension as opposed to one of the other letters, and so on and so forth. So the specificity is a challenge, and the specificity forces us to think about whether a condition in the current encounter or in the current environment is or is not an HCC. So some of those specific elements, laterality, of course, is this the right side or the left side of the body? Where exactly on the body is it occurring? And ICD-10 is much more specific about that. Manifestations and underlying etiology. So when we think about not only the manifestation that we're coding today, but the underlying cause as well, there are a lot of circumstances where we would have had 2 or more codes in ICD-9, one of which triggers an HCC. Now we're in ICD-10 and we have one extremely specific code that tells us manifestation caused by this underlying etiology. This ulcer is caused by this type of vascular disease. And that kind of thing. So we have a very specific individual code that now triggers the HCC, or in some cases triggers 2 HCCs, which we'll talk about momentarily. So getting those codes precisely right becomes very important. Episodes of care, as I mentioned, when we think about fractures, for example, and there's a relatively limited number of fractures that are risk adjusting, but only certain episodes of care do risk adjust, specifically the initial episodes as opposed to subsequent or follow-up. Some sequelae adjust, but some do not. So sequelae, what we call late effects mostly in ICD-9, becomes something that happened after the fact as the result of the initial disease or as the result of the initial injury. And when we have relatively complicated medical situations where an underlying condition or a previous condition is now causing a problem, that fact, that relationship risk adjusts in some situations. Simply saying, here's the new problem, often that code doesn't risk adjust. So being very specific about those relationships is very important. And staged conditions, ulcers, be they either decubitus or non-decubitus now. Pressure ulcers in ICD-9 obviously have a stage 1 to 5, but non-pressure skin ulcers, chronic skin ulcers, did not. In ICD-10, there's actually very specific codes with respect to the depth of the ulcer. So these kind of things, very significant in terms of making sure that we get appropriate HCCs triggered. Mention laterality and body site. ICD-10 can be much more specific regarding a particular body site at which an injury or illness is present. That includes left or right or bilaterally. If the site or side of the body is not identified, we're going to use an unspecified code. In many HCC models, these unspecified codes are not acceptable and will not risk adjust. So it now becomes important for us to correctly identify the side of the body. As I mentioned, many ICD-10 codes identify manifestations of chronic conditions. The documentation needs to clearly link the manifestation to its underlying cause, except in specifically named exceptions. We're looking for language such as with, in, or due to, in order to make that link. For infectious diseases, ICD-10 includes many specific codes regarding the body systems or the organs affected by the infection. So again, we want to be as specific as we can. ICD-10 includes codes to identify the underlying cause of conditions, including the specific infected organism for conditions resulting from infection. So whenever possible, it's important to be specific about these things. Sometimes that specificity is the difference between risk adjusting and non-risk adjusting codes. Specific manifestations of an underlying condition will appear in certain risk adjustment models with different values. Acute diabetic complications versus chronic diabetic complications versus diabetes without complications, different values in the model. So it's important for us to know which we're talking about and to code appropriately. Episodes of care. So we know ICD-10 injury codes, including fractures, identify the episode of care through a 7th character extension. Provider documentation should clearly represent the episode. Is it an initial episode of care? An initial is defined, and some folks are often unclear on what is and is not an initial episode of care. New injury or new provider or provision of the definitive care for that injury. Follow-up versus follow-up care, which is a different category and usually does not risk adjust. Care for sequela or late effects which result from the injury. For fractures also, that 7th character extension will give us additional information regarding the severity, the type of fracture, open or closed, displaced or non-displaced, type 1, 2, 3A, 3B, or 3C. Routine healing, delayed healing, malunion, or non-union is all identified there as well. And the cause of the fracture is dependent upon the code. Traumatic fractures versus stress fractures versus pathologic fractures are all separately coded in ICD-10, have different risk adjusting values and need to be properly identified. Here are some of those 7th characters which you're probably familiar with. The initial diagnosis, subsequent visits with routine healing, delayed healing, non-union, malunion, etc. When we talk about using the 7th character of A for active treatment, and that's the guideline in ICD-10, tells us that it's for active treatment. Active treatment includes surgical treatment, emergency room encounters, evaluation, and continuing treatment by the same or different provider. So all of that actually qualifies as the initial episode, the 7th character of A. While the patient may be seen by new or different provider over the course of treatment for a pathological fracture, assignment of the 7th character is based on whether the patient is undergoing active treatment and not whether the provider is seeing the patient for the first time. And that's a significant point. When a current condition is a sequela or a late effect caused by a previous condition, trauma, infection, or other illness which results in a chronic status or a chronic condition, the documentation should clearly indicate this situation. And ICD-10 includes codes to represent sequela in the context of their underlying causes. Some of those causes or some of those situations will risk adjust while some do not. So it's really significant for us to make sure that we're clear on the differences. I mentioned staged conditions. When a diagnosis is commonly identified by a particular stage, documentation should identify that stage. Common examples are glaucoma, chronic kidney disease, and decubitus ulcers. ICD-10 allows the identification of those stages within the code set, so obviously we want to be choosing the correct codes. Only certain stages of some illnesses are included in the various HCC models, so documentation and coding has to identify the correct stage for us. Chronic kidney disease of an unspecified stage is not accepted as an HCC in most models, so knowing the stage is critical. Stages 4, 5, and end stage are HCCs in most models. When I talk about most models, I don't, and some of you folks may be in just Medicare, just commercial, some of this kind of thing. So we're thinking about the Part C risk adjustment model for Medicare Advantage, or Medicare Part D model, the various Medicaid models, which is CDPS in many states, but some individual states have other models they use as well, and also the HHS HCC model, so commercial risk adjustment, health insurance exchanges risk adjustment. Next area, common confusion regarding ICD-10. Some areas where folks get tripped up. ICD-10 includes numerous combination codes which represent multiple related conditions existing simultaneously within the patient. So one code, multiple conditions, all there at the same time. In some cases, one code may trigger multiple HCCs. So I mentioned this a moment ago. There's one code, diabetic peripheral vascular disease, E11.51. Specifies the type of diabetes, but this applies to all types. .51, diabetic peripheral vascular disease, maps to both HCC 18, which is diabetes with chronic manifestations, and to HCC 108, which is vascular diseases. So one code is now triggering multiple HCCs. That's really new for us. There's nothing in ICD-9 that does that. If you were coding this, of course, in ICD-9, you'd use a 250 code for diabetes with vascular manifestations, and that would trigger HCC 18. You'd use a second code to identify peripheral vascular disease, and that would trigger HCC 108. Two codes, each triggering an individual HCC. But in this particular case, one code is doing double duty here. That's really a new concept. That's something we haven't wrestled with before. If you have an Excel spreadsheet, a macro of some kind, a more sophisticated computer system, something that's actually computing these risk scores or computing the value of what you've coded, suddenly it has to give you sort of double points for one diagnosis. That's sort of something we never thought about before, and that folks have had to go back and really incorporate. Remember to apply ICD-10 codes for dates of service, October 1st, 2015 and later, but ICD-9 codes must still be used for earlier dates. And as I mentioned, many risk-adjusting organizations, particularly Medicare, are right now working on reviews for 2015 dates of service because their final submission is the January 2017 sweeps period. And so if you imagine coders who are looking at a 2015 record, as they go through it, if the date of service is up until September 30th, they're using one set of codes. And if the date of service is after September 30th, this is October 1st or later, they're using a different set of codes. And your coder is actually having to sort of switch gears in the middle of that record. I'm on 9 here, I'm on 10 here, go back and forth. And as much as we would like it, some medical records are not entirely in chronological order. So I think I struck a nerve. If you imagine going through, here's one from October, here's one from March, here's one from December, here's one from January, I would need more coffee at that point, I think. So there's a real challenge there and a real potential point of confusion as coders attempt to review 2015 days of service. Question?
Yes. Go back to diabetic peripheral vascular disease.
Yes, ma'am?
So do the doctors still have to link those two disease processes in their documentation in order to use that code?
So that's coming up. The answer is, at this point, no, according to the official guidance. And most people shake their heads like that lady behind you when we talk about that. It came up in a presentation on Track A yesterday, and it derailed the whole thing for about half an hour, to tell you the truth. Here we are here. Well, we are about to jump headfirst into that topic. So, first of all, thinking about Coding Clinic and how we apply Coding Clinic to ICD-10 is a little bit of a challenge, because obviously Coding Clinic was written to address specific questions in ICD-9. Fall of 2013 was the last meeting of the AHA Coding Clinic Editorial Advisory Board where ICD-9 questions were addressed. On January 1st, 2014, after 30 years of providing ICD-9 coding advice, the AHA Central Office shifted its attention to ICD-10 and no longer accepts or responds to requests for ICD-9 advice. That was in 2014, even though we went another almost 2 years, year and 3/4 before we moved on. First quarter of 2014 was the last issue of Coding Clinic for ICD-9 and the first issue of Coding Clinic for ICD-10. Now, existing Coding Clinic guidance may be applied to general scenarios, but code-specific instructions cannot be directly translated from ICD-9 to ICD-10. This is what Coding Clinic tells us. So there are subjects that they covered under ICD-9 that give a general scenario. The doctor has documented this. I would code A, B, and C. Then you could take that scenario, you could move it from ICD-9 to ICD-10 and code it that way. But when you get into the intricacies of when to apply a specific code, which Coding Clinic sometimes does, we can't necessarily rely on the ICD-9 version and simply translate the codes over, because there's different guidance. The codes are listed differently in both the index and the tabular in ICD-10 than in ICD-9, which is where we get into the diabetes question. And so we're not able to do that. So did I not talk about? I don't want to jump the gun and talk about, okay, yeah, Samantha's going to talk about the diabetes thing here in a moment, so. It's in there, I promise. So briefly, the 2017 updates, there are many new and revised codes taking effect October 1st, 2016. Remember that these are for that date of service and later. So you still have a scenario, as you look at 2016 dates of service, where the previous set of codes is used up through September 30th, and the new set of codes is used from October 1st forward. There are a large number of changes because once CMS decided they were going to finally implement ICD-10, the code set was frozen for a longer than normal period. Most of us probably remember that when things were going on normally under ICD-9, every October you'd get a few changes to the system, and you'd have to apply them from that date moving forward. And it was usually not too onerous because there were not too many changes. Because it's been, I think, more than 2 years since ICD-10 really had an update, there's a huge number of updates that they've been waiting to put in here. And so consequently, it's a pretty big change, and there's a lot going on. While no HCC models have been formally updated yet to incorporate these new and revised codes, the following are changes we expect to affect HCC coding. There are added codes for gastrointestinal stromal tumors, and this is a really abbreviated list because it is like literally a 4-hour webinar that I sat through to go through all of the changes for 2017. But new codes for gastrointestinal stromal tumors, which are cancers, and will need to be incorporated. New codes specify which eye, right, left, bilateral, unspecified, for diabetic ophthalmic manifestations. So if you can imagine, there are something like 170 new codes under diabetic manifestations because you've got it for all, 5 types of diabetes: type 1, type 2, drug-induced, other, and I'm blanking on the fourth, fifth one. But so new codes for every possible ophthalmic manifestation now identify, is it the right eye, is it the left eye, is it both eyes, and so on and so forth. They've also added codes for diabetic tractional retinal detachment, stable proliferative diabetic retinopathy, and diabetic macular edema, which is resolved following treatment. Like massive number, like almost 200 new codes specifically for diabetic eye manifestations. Now codes for hypertensive urgency, emergency, and crisis. We didn't specifically have those things previously. Hypertension generally is not in the Part C model, but it definitely is in Part D, so it will have an effect on some folks. New codes for cerebral infarction due to disease of specific arteries bilaterally is now an option. Dissection of other specific arteries, there's a handful of new codes for those. Necrotizing enterocolitis is now specified. Expanded codes for pancreatitis with and without necrosis or infection also included. And chronic pancreatitis, of course, is a risk-adjusting condition in most models. Acute pancreatitis also in some models. Atypical femoral fractures, in addition to the existing fracture codes. A malfunction, infection, or other complication of catheters and stoma of the urinary tract are, we believe, likely to be included. Ectopic pregnancies clarified as existing with or without intrauterine pregnancy. So previously, ICD-10 didn't specify, in the presence of an ectopic pregnancy, is there also an intrauterine pregnancy existing at the same time, which does occur. So that's now specified. Obviously not relevant for Medicare for the most part. Most Medicare beneficiaries aren't pregnant, but the commercial model includes a lot of pregnancy complications, so it's relevant there. And revised coding for pre-existing diabetes in pregnancy, also going to be relevant there. So all of that said, I'm going to give Samantha the unenviable job of discussing some of the specific HCCs and diagnoses of interest, which definitely includes that diabetes question, and we'll be glad to go on at great length and miss lunch if we need to talk about that, because coders love to argue about that particular point. So let Samantha jump in here. Thank you.
Thank you. That was
Of course.
excellent. All right. Thank you so much for being here. And Tim did an excellent job of really providing a high-level, wonderful high-level overview, and had some specific updates as they referred to codes. So we're going to look at now specific HCCs and diagnoses of interest under ICD-10. So I code in particular for the MA population, so Medicare Advantage population. And of course, chronic obstructive pulmonary disease is one of the more common chronic conditions that I encounter when I'm reviewing chart notes. A change between ICD-9 and ICD-10. In ICD-9, asthma in the presence of COPD coded to 493.2X, chronic obstructive asthma. What we see now on ICD-10 is that COPD is coded to J44 point, and an additional code is applied to identify the type and the severity of asthma, J45 point. And then we have here an example where we have our code for COPD unspecified, and then again we're instructed for that additional code for the severe persistent asthma uncomplicated. So in ICD-10, types of asthma are no longer coded as extrinsic, intrinsic, or chronic obstructive. Instead, ICD-10 utilizes mild intermittent, mild moderate, severe persistent, and other and unspecified. So in ICD-9, asthma in the presence of seasonal allergic rhinitis, also known as hay fever, is coded to 493.0X, extrinsic asthma. The ICD-10 index directs the coder in this circumstance to asthma allergic extrinsic, which codes to J45.909, unspecified asthma uncomplicated, also asthma not otherwise specified. So we touched upon this earlier. So with diabetes mellitus, ICD-10 introduces many changes to the coding of this condition and its many complications. So now we have in ICD-10 5 categories as opposed to 2 categories that exist in I-9. So we have now E08 for diabetes mellitus due to underlying condition. We have E09 for drug or chemical-induced diabetes mellitus, E10 for type 1 diabetes mellitus, E11 for type 2 diabetes mellitus, and finally E13 other specified diabetes mellitus. So because all type 1 diabetics are insulin dependent, the code for long-term current use of insulin is not necessary to use when you're coding for a type 1 diabetic patient. So most combinations of diabetes, the etiology, and the manifestation complication can be identified with one ICD-10 code. So essentially, the manifestation or complication is built into the diabetes code. Coders will still take great care regarding the specificity of such codes. A second code is still utilized. So there are some exceptions given certain circumstances to provide greater information. So if you have a diabetic with chronic kidney disease, ICD-10 still instructs you to use an additional code for the stage of CKD. If the patient were to have a diabetic skin ulcer, ICD-10 instructs you to identify the site and the stage of that ulcer. Also, other diabetic ophthalmic manifestations, such as diabetic glaucoma, and then there's some other conditions that are not encapsulated in a combination code. In that case, you would use an additional code. So this is another big change between ICD-9 and ICD-10. In ICD-9, out of control, uncontrolled, this was actually identified by the 5th digit of that numeric code. In ICD-9, we're actually instructed to code by type and then also use an additional code if applicable for the hyperglycemia. So again, our default when we encounter diabetes, our default type, unless it's otherwise specified as type 2, there's actually a code E11.65 which indicates type 2 diabetes with hyperglycemia. There's also, for diabetes with hypoglycemia, it's coded with 1 or 2 manifestation codes with or without coma. E11.641 for type 2 diabetes mellitus with hypoglycemia with coma, and E11.649 for type 2 diabetes mellitus with hypoglycemia without coma. Say that 10 times. So under ICD-9, it explicitly stated in the guidelines that in order to code for a manifestation of the diabetes, there had to be a causal link in the documentation indicating that the manifestation or complication was linked to the diabetes, was caused by the diabetes. Such verbiage would be diabetic, preceding the particular condition. There was also verbiage diabetes with, causing, related to, due to, secondary to, related to, caused by diabetes. So we as coders, those of you here, I can remember that this was a very important concept in our own coding, and then of course if we were in a position where we were educating providers, giving them feedback, this was, at least for me as a coder, very common feedback, very common education to those providers. So Tim alluded to this earlier. There has been recently an AHA coding clinic, and Tim also referred to AHA. This is really one of the only CMS endorsed coding guidance out there. That there are new instructions for diabetes and complications. So that they are stated in third quarter 2015, page 21, and first quarter 2016, page 11 through 13. So this really, quite frankly, this was like anathema to most of us coders. When we read this guidance, this really changed our orientation to coding. And essentially what the guidance states is that a specific linkage is not required between the diabetes and certain complications and manifestations when referring to conditions listed in the ICD-10-CM index under diabetes, diabetic, mellitus, sugar, with. So essentially what that's saying is, if you were to open up your ICD-10 book and you would look for diabetes, diabetic, there's a statement next that says with, and then indented would be all of the conditions that if you were to encounter a chart note in which diabetes was assessed and chronic kidney disease was assessed, but there was no documentation supporting a causal link, that you as the coder can infer or assume that causal relationship. And again, that doesn't go for all conditions that could be manifestation of diabetes. It only goes for those that are indented in the index after diabetes, diabetic. So this is a list here that, according to AHA Coding Clinic, these are all of the conditions that are indented after with, in which the coder could assume the causal relationship between the diabetes and these particular conditions. So again, this was really, clearly it's garnered a lot of conversation, and it was really anathema to how we as coders have been coding. So again, there's ongoing conversation about this. There are definitely among coders and providers some pretty significant differences in opinion. So I know that I know that you have a question to ask or a comment. Yes.
So I guess the clarity that I need is, if the doctor says diabetes, or if he, in his assessment, diabetes with PVD, but there's nothing written about the PVD in the chart note itself. However, on the exam, he has the monofilament that's positive. So can we assume that we can add that polyneuropathy code?
I would, so you were talking about PVD, or are you talking about polyneuropathy?
The PVD, oh, sorry.
Okay,
PVD.
I just want to be, okay.
Yeah, sorry.
That's okay, that's all right. So the practice that I follow is that unless the provider states unequivocally verbatim that the patient has polyneuropathy, that I cannot as a coder make that inference. If I was in a position where I could query that provider and ask them, could this be peripheral neuropathy, then certainly they could amend the chart note if indeed that's correct. But I would not make that inference, just
okay,
based
so
on
let's
symptoms.
go the other direction then. If there was no monofilament test or anything said about that, and the doctor had just put in the assessment the E11.51, can we...
And there was no meat?
Right, for that PVD.
Again, this is going to come down to coder discretion. I would not pick that up. I take a fairly conservative route. Do you want to weigh in what you would do?
Really, that's.
When this came out on Medicare Call, it's like, what the?
Okay, it's sort of a different question, first of all, from what I thought you were asking initially, so I apologize for that. But you're talking about a situation where a provider's written diabetes with some manifestation, and there's really nothing in the record that speaks to that manifestation. I think that exists on an organization by organization basis. I will tell you, so personally, in the basic guidelines that we utilize at Episource, there's actually a clause that speaks to this point, and it says that if you have a combined condition, if you have a situation where you've got diabetes causing whatever it's causing, for example, our view is that treatment or management efforts which are directed toward half of that condition can be used to support the coding of the entire condition. So my particular approach would be, has he done anything for the diabetes? If we're talking about, we did an A1C, check the blood sugars, and here's what they've been looking like. Patient's going to continue on this dose of metformin. Now, in my view, the provider is speaking to the diabetes, and since we know the diabetes is causing the neuropathy, vascular disease, whatever it may be causing, that's ultimately treatment for the whole situation. So my particular view is that I would in fact code diabetic peripheral neuropathy or diabetic peripheral vascular disease or that kind of thing. Now that's our particular guideline, and anytime I get in a coding project with somebody, one of the things that we do first thing is go through those guidelines, and you or your organization may take a slightly different approach to that, but for my part, that's my view.
Samantha, have you started to tell your docs?
No.
Because scan won't touch this. I mean, we've gone so hard on this causality thing on Scan University that we just won't touch it. Because we feel like our credibility is on the line, and we just don't want to blow with the docs.
And how will that be remembered?
We just got done, like a month ago, screaming at you for causality. Now you don't need to do it. What do you say? Oops. So I'm just curious. Tim, are you guys gonna start telling folks to change their guidelines? Or are you gonna leave it alone? Because the causality isn't a problem, right? The linkage isn't a problem.
One cannot use too much documentation unless it detracts from or causes conflict as to whether or not the diagnosis is valid.
So we're just no longer going to scream about it, right? And that was our.
And that brings up a really good point, because at the health plan, we spend our days when we're coding looking at less than ideal documentation. And we don't have the opportunity to query our providers for clarification. So we have to work with what we have. And so there have been situations, and this is why this is the gray area, these are the nuances, where the situation that you described, I would actually pick up the combination code for the diabetes and the manifestation. If I was, from a risk adjustment HCC capture perspective, if I was speaking to a provider and educating providers, which is part of what I do, then I would ask them to beef up their documentation to make it ironclad that they really should have some monitoring, evaluating, assessing, or treating for the manifestation. But again, because we're often looking at less than ideal documentation, that would be an area where I would likely capture the code.
Yeah, because in I-9, we would downcode it to the diabetes no complications and just leave everything else off because it wasn't supported.
Right. And I'm sorry, you had a question or comment?
So I'm a physician and a coder, so I'm schizophrenic, so I'm in a schizophrenic comment. So for the clinicians, not linking them makes absolutely perfect sense. And in some of the linkages that were in the past in the coding environment were crazy. And the example I'll use is diabetes with kidney problems. So the number one cause of kidney disease 50% of all kidney disease is caused by diabetes. 25% of all kidney disease is caused by hypertension. So the coding rules said we'll automatically link the 25% cause, but you have to give me verbiage to link the 50% cause. And so clinicians, that made no sense. So and similarly, the number one cause of blindness is diabetes and peripheral neuropathies, and I mean just gangrene and vascular. It's all diabetes. So to link them from a clinician seemed silly. So so that's my clinician. Now my coder hat. Because I go and I teach our physicians, I'm going to teach them to say diabetic and due to diabetes and all those kind of things, and use this rules as a safety net in case I'm audited by the government. So I'm going to keep it as my safety net because if wherever the bar is, the physicians are going to go a little bit lower. So, so I'm speaking as a coder now. So I just as soon raise the bar a little bit and then use this as an absolute. Because it makes perfect clinical sense, but at the same time, from a documentation and a revenue standpoint, I want to make sure how hard is it to change the diabetes ES to IC.
Right.
So anyway, I'm going to continue to train my docs. If they bring this up, I'm going to say, you know, they're arguing over it, and so until I hear for sure when we've passed some audits, we're going to continue to say diabetic.
And that really speaks to Dave's question about, is anybody actually talking to doctors? No. Nobody I know is actually going to doctors and going, just kidding, you don't have to actually do that. They're like, let's just let them keep doing what might be a little too much.
So you actually, so the credibility thing, it might be good news. There's always, so I used to do talks on coding in the clinical world collisions, and this was always one of them. And so asthma was one of them. Because we've been saying intrinsic or not, we've been saying mild, moderate, severe, intermittent, all those things for years, and ICD-10 finally caught up. So what I do with my docs is say, good news, the documentation and coding world is finally caught up, so now we don't have to link diabetes anymore. And I go, oh, good, it's about time. So I think if you approach it like that it's always behind because diseases come about faster than codes do.
Right.
So it takes a while for it to catch up, and good news, they've caught up. Great, thank you. Now, I'm still not going to tell them that, but because I want to have my safety net in place.
But if you get pushback because a doctor has actually looked at the code book and read it and wants to argue it with you, that's something that we can.
Right. So that doc, I say, good news, they finally caught up. You don't have to link them. I'm saying you never know what the government's going to do, so let's link them until we've got. You know, there's the theory and then there's the practice. So when we have the practice that they're actually accepting it, then I'll believe it. But until then, I don't want to get dinged on an audit because I assumed they would do something that was rational.
It seems like a perfect time to point out. There's a couple of coding sessions today. Jim is going to be talking a bit later today at 2:20. So, I encourage you, for those of you that are passionate about the subject, come back and continue the
and I'll shut up. So
we're a little late on time.
Okay, should we?
And is there just like a couple points that you wanted to?
We could just move through really quickly. I don't think there's very many slides left. Really good conversation. So we talked about, of course, making the linkage here, with the exception being if the provider were to clearly state that a condition is not related to diabetes, then you of course would not make that inference that they are related to each other. Very quickly here with hypertension, in I-9 we had malignant, benign, unspecified forms of essential hypertension, separate codes for those. Those are now all represented by one code, I-10, for essential primary hypertension. This is another big one. This is probably something that those of you in the audience could speak to. Depression. We got our providers, when we go out and do education, really good at including the descriptor major. Major depression used to risk adjust. In I-10 it does not, unless at the very least the severity of the depression is stated. Of course, to code to the highest level of specificity, we would also like to know the episode as well. Angina with CAD, here, we have, again, these are two separate codes in ICD-9. Now there are codes that incorporate both conditions. For the atherosclerotic heart disease, those codes with angina, those carry risk. So that's it very quickly through the last slides. Any other questions, commentary? Yeah.
I've got two last quick questions, because I am also on the clinical side and I do a lot of audits for nurse practitioners. They love coding diabetes with unspecified complication as diabetes with hypertension or diabetes with hyperlipidemia, which I discourage people from using. Is there some kind of meat that people look for to actually justify such a diagnosis? Because it seems impossible. What's your opinion as a coder on that?
You know, we talked about this because what we frequently see in some of our more larger practices in their EMRs is that they're selecting diabetes with other complications, so not unspecified but other, and then there will be a statement with hypertension with hyperlipidemia. So we talked about that at length because our understanding was these are not typically manifestations of diabetes. They may be comorbidities, but they're not manifestations. And essentially we landed at, the provider, we're going to defer to his or her clinical judgment. If they're saying this particular condition is a manifestation of diabetes, then we would pick up the diabetes with other manifestations. In the HCC-MA model, neither the hypertension or hyperlipidemia risk adjust, but of course diabetes with other manifestations.
And then the other quick question was with the CAD with or without angina, if the cardiologist is documenting without angina repeatedly and prescribing nitro tablets repeatedly, how do you deal with that as a coder?
Now, it sounds like you can interact with and query your providers. I would use that as an opportunity to point out that disconnect or that difference. If I was looking at that, ultimately I would say, gosh, I'd really like to speak to this provider, but they are selecting a code that states without angina, and so that is their assessed diagnosis, and that's what I would
So
go by.
that risk assessment that's going to start looking at pharmacy records that we're talking about, is that going to pick up that sort of thing?
I'm not familiar with that. Can you speak to that, Tim?
So if they're
Is
prescribed
this the
nitro, that's
RX
gonna-
model? Or?
And I think they would probably have to document the reason for the nitro.
Well, so the reality is a lot of times, and I've done it, somebody's got CAD, I'll give them the sublingual nitros.
Just in case.
Just in case.
Right.
Whereas if I put them on a long-acting nitrate, I'm treating their angina.
Right.
So anytime I get something CAD and there's no mention of angina, but I see that they're on long-acting nitrates or a beta blocker or a calcium channel blocker, I query the doc and say, hey, I noticed they're on some medications that can be anti-anginals. Is this patient chronic stable angina? And a lot of times I go, no, they've never had angina in their life. Oh, okay. Because they're on the beta blocker for something else.
Right.
So when I see that, I at least query them to get it clarified that they really should be without angina.
Thanks.
Yeah, thank you.
Brilliant, thank you.
Thank you. Oh, yeah, you're welcome. Thank you. Thank you very much.